Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there. We're so glad that you've chosen to join us today, because one of the things that we really like doing is just sort of floating around and hitting on the salient points of Vein Clinics of Hawaii, what they do. And as you know, it is a great cast, and those of you that are already patients know that. And there are so many different things that go on there, and one of which really circulates around a able-bodied technician who knows what he or she is doing in the diagnosing and in the testing that needs to get done. And before we introduce our special guest of the day, Dr. Juliff, being on 4 islands, it's really important that you have staff that you can trust and staff that have that level of expertise. So let's get right into it today, because we need to get our friend Mike on the air and then out of here, because he's got to go back to work.
Right.
Unlike us. So let's talk about something that you and I talk about on a regular basis with the real expert. How long has ultrasound been used as a diagnostic tool in vein disease?
Oh, it's been a while, probably 25, 30 years. But the technology behind ultrasound, it just keeps improving, with each advancing year. And
you're talking about in the technology, the equipment,
the software and whatever. But our ability to visualize blood vessels with ultrasound, it's tremendous. It's a tremendous tool. And with respect to what you were saying before, having an ultrasound tech, as well as everybody in the office that you can rely on. But, ultrasound in particular, it all starts with that. We use ultrasound so extensively in the office that
is it hard to even think what it would be like if somebody said, "Hey, Doc, by the way, your ultrasound thing's broken today. You can't have it."
Yeah.
Oh.
Yeah, that would put us away.
Get the backup unit and do it quickly.
Yeah. So we rely heavily on the expertise of our ultrasound techs.
Are there travel portable put in a suitcase and go units?
There are. Yeah.
That's pretty cool.
That's the other thing that's the other kind of mechanical development that's happened over the past, I would say 10, 15 years maybe. They've become so compact. I can remember being, in the hospital years ago, these huge ultrasound machines that, the techs would be pushing around, just tremendously heavy and very big. But you could basically put it in a suitcase.
One thing that needs to be asked, and we do this from time to time, and that is the investment that has got to be made in doing what you and others do to open these clinics when you have all of this equipment all over the place. It must mean that, you need to stay up with things, but you don't want them to be replaced. Like, remember when computers or the iPhone changed every 8 minutes? If you didn't have the new one, I don't want to work for you. I want the new stuff.
Yeah. Luckily, ultrasound machines are not quite that bad. But you have to have reliable machines, and we have several ultrasound machines in pretty much every office that we have. So
well, we have actually had Mike in here before. Tell me a little bit about Mike, so we can start picking his brain about the patient experience, and also for those of you that are out there, if it's been a while since you've looked into your veins and your vascular system, and you hear some of the symptoms that we talk about, you got to giddy up and go to veinclinicsofhawaii.com and make an appointment to come in and find out what the new vein clinics look like, right?
Right, exactly.
Okay, so once again, how we came across Mike and what function he performs.
Well, Mike, just fortuitously, he was looking for a job the same time we were looking for an ultrasound tech. And
planets lined up.
Yes, yeah. And, I feel like we were very lucky that happened. Mike was in California, which is where he grew up, and he had an ultrasound tech kind of company that he owned and ran, but I think got tired of having fun on the highway in Los Angeles.
So now you can come here and have the same kind of fun, but no highways. Right?
Yeah.
Unless you happen to be around sometime on a Monday morning after a long weekend when it's not too much fun.
Right.
But that being said, and so it's pretty neat. And Mike, welcome to the program, and it's nice to have you back. I remember when we met the first time you were here, that you're a surf kind of dude anyway, so Hawaii's just the right for you. So you've been here how long?
I've been here almost 1 year now.
Yeah, that's pretty cool. And so, Doc, based on previous discussions that we've had, the thing that prevents anybody from opening a new restaurant or another clinic, like in your case, 4 on 4 islands, you need to have the kind of staffing that you need. And here comes Mike at the right moment.
Right.
But I'd be interested to know, how did you even get interested in the technology in the first place?
Well, I kind of just fell into the field back in about 2010. I knew somebody who had a sister who was in the field, and I spoke with her, and it kind of sparked my interest. And in school, you kind of, you learn every area of ultrasound, and you kind of get drawn to one area. I got drawn into the vascular arena and started specializing in vascular ultrasound, and then later cardiac ultrasound, echocardiograms, and that's kind of how I got going.
I think it's kind of interesting, Doc, that Mike's that way, because we don't know what motivates you. It's like when we talked about you're changing from being a heart guy into a vein guy, that it's your calling.
Yeah.
So here comes something. It would seem to me that anybody can buy the ultrasound equipment. If you can go to the ultrasound company, buy one, but I guess there are ways to use it and ways to use it. And when you find somebody that you trust, you would expect to get a standard or a set rule of accomplishments every time somebody goes to work.
Yeah. Ultrasound. When you begin to study ultrasound, ultrasound is used in so many different arenas. We look at abdominal contents with the ultrasound, and we look at other soft tissue things. And I think Mike mentioned that at some point he moved from that and became attracted to vascular ultrasound. But doing venous work with the ultrasound is even a step above that. Not everybody likes it, but yeah, as you mentioned, I mean, it's something that you are drawn to if that's going to be your bag. But
well, thank goodness for all the ingredients, right? Because you need them all. And the thing, Mike, that now that I've actually had you do that with me, I think that the same thing must hold true. I am fascinated by the way you can touch somebody with a probe, and you can look at the screen, and when you release it, and you can see the squirt this or the squirt that. And I know it's not just a video screen that's been made to entertain people, but that's kind of like, is there a set path that you go through on every examination you do?
Yeah, I mean, you have a general idea of what you want to find in a patient or what you're looking for. Everybody's anatomy is basically the same, but the superficial venous system does have a lot of variations. So you go in there with an idea in mind, a protocol, but then you definitely have to stray away from it pretty frequently.
Let me ask you this, because I used to be what was called morbidly obese. I was really a big guy, and I'm still kind of a big guy, but not like I was before. Is it harder to do ultrasound on some people that are physically larger than others?
Sometimes, yeah. Sometimes, definitely.
Yeah. The reason why, and I've shared this with Doc before, is I had hip surgery a long time ago, and the physician now, who's actually a friend, said, man, I wish I'd have done you now instead of then. You were a pain in the you-know-what. So I'm imagining, even though you said everybody's kind of similar, if you've got a foot more skin in between me and the vein, it might be tougher to see. Yeah. How far into my leg can you see?
I can see in probably, like, if I really want to get good, like a good idea of what's going on in the vein, I don't want to look deeper than like 8 or 9, 10 centimeters with the vascular probe that I'm using. If you're using a different probe, then you can penetrate the skin a little bit more. So, with my probe that we use with venous ultrasounds, we don't really look deeper than like that. After that,
now when he's talking about it, you're looking at about 5 to 6 inches or so, maybe a little bit more.
Ish.
Yeah. But what I'm thinking is really neat, Doc, and you've talked about this before. If somebody has deeper problems than that, and we talk about that, maybe you guys can explain the difference between the deep vein system and the other vein system. What we're really looking at with the ultrasound is not the big ones right in the middle, right?
Well, we do that.
Yeah,
when we do a venous ultrasound diagnostic study of the lower extremity, we're looking at all the veins because it's important to know the functional mishaps going on in the deep system too. Now, luckily, most people have normal function in their deep system. Most people with varicose veins and the usual kind of symptoms primarily have superficial venous insufficiency, but yeah, that's all part of it too. We definitely want to look at everything.
Okay, and because one of the things that I want to get into during the program today, Mike, is the impression that people have that maybe they haven't been to a vein specialist for years, and they had maybe some spider veins done when they were young, but now they're symptomatic of a bigger problem. They come in, and you must be pleased as punch because you're one of the front guys on the front row to explain what you do, because they must say, man, where's all the butcher equipment that I used to see when I came in here? What's going on with me? Do you get that with some of our people that are nicely aging in place that need to get looked at?
Yeah, we get people with a lot of past vein history, vein treatment history. We have patients who had procedures called vein stripping, like 20 years ago. And vein stripping was a very invasive procedure that was an inpatient procedure at the hospital, and a lot of downtime, very painful, very difficult on the patient. And then when I explained to them what the modern vein treatments are like, it's they're definitely pleasantly surprised. We also have a lot of patients who keep going back to like dermatologists for spider vein injections, and they don't understand that initially that the spider veins are going to continue coming back because they're not treating the underlying problem. When you have superficial venous insufficiency and you inject just the spider veins, but you leave like the great saphenous vein or the small saphenous vein or anterior accessory saphenous veins, then your spider veins are usually going to keep popping back up unless you treat those veins as well.
Yeah, it may not be. I think, Doc, you've explained before, it's not the same vein, the spider vein. But if that part of your body had some spider veins and you fixed them or shot them, you're going to get some more.
Right.
Because that area is attractive to spider veins or something. Right?
Yeah, well, the underlying, like Mike was saying, the underlying function of the superficial system is definitely having an impact on what's going on, at the level of the skin. And it may not be the same exact spider vein that comes back, but it's probably going to come back in some way.
The thing that I did get fascinated at a little bit, Mike, was it's sort of neat to me, the level of communication that you must have to have with the doc, because consistency in examination makes the doc feel if you have to examine me and he's not there, that what you do. And I noticed this guy, he's kind of like, he's ambidextrous, because one hand he's doing the ultrasound, the other hand he's writing, and I think he can go back and forth. Because isn't it sort of neat that does the machine actually record a ultrasound, or does that translate to the chart that you're doing physically next to the machine, or both?
I take images on the ultrasound machine and I take clips. And then I also am drawing, kind of mapping out the venous system as I'm doing the ultrasound. But then I'll go back after the ultrasound exam is done and then kind of fill in all the blanks with the images and clips that I have taken.
Yeah. And isn't that, once again, consistency is the key, right?
Oh, yeah.
So that when you come in to do a surgery. And there's another question. Somebody else actually asked this. Do you employ the use of the ultrasound during the procedure sometimes?
Yes, we do.
Yeah, that's kind of neat.
Extensively. Yeah. I mean, the ultrasound allows us to do what we're doing now in such a minimally invasive fashion, as opposed to vein stripping and all the surgical stuff that we did before. Using the ultrasound allows us to do that.
That's really interesting, and I guess maybe, Mike, it sort of dovetails into why you decided to pursue this particular thing. So I guess when you go to a clinic, what's it like knowing that, okay, you're going to provide the doc or the surgeon with the information that they need. They're going to go in and fix somebody, and then you're going to keep track of them 6 months later or a month later when they come in for a shave and a haircut to see how things are doing. Do you remember patients' legs?
Oh, yeah. I mean, you usually remember patients' legs. Sometimes the names and the faces get a little blurry, but you always remember
that's pretty
the venous
neat,
system.
You know?
Yeah,
I've seen that leg. I think it's Bob owns that leg. But I'm still interested in the actual procedure. And I do know that there's probably no set answer, but generally speaking, when you do a thorough ultrasound test on somebody, about how long do you spend with them?
Usually I'll spend, if it's a new patient, somebody who's never had any treatment before, I'll spend about 30 to 45 minutes with them. If it's a patient that I've seen before that I'm just checking to see how they're doing after a procedure, I may only spend 20 minutes or so.
Yeah, because that's what sort of, and I'm glad that we're doing this program with Mike now, Doc, because that's sort of what I'm going to do now. I'm coming in based on you taking a look at my legs a few months ago and discovering a treatment plan. Now I'm going back in, and I guess the first thing is Mike's going to take a look to see if there's been any changes from then and now. Is that how it works?
Oh, yeah, absolutely. I mean, I do a full ultrasound. I look at all the same veins that I looked at before, except now I'm seeing things a little bit differently. We close superficial veins, so I'm making sure that the veins that we treated are closed. I'm making sure that your deep veins are nice and open, that there's no blood clots or any sort of complications. And then I'm also checking to see if there are any more superficial veins that are open that that could be potentially causing a problem. And I check the valves in the open superficial veins as well. Yeah,
and I think, Doc, maybe you guys can go back and forth on your own on that end of it by talking about what level of expectation. In other words, I come in and I fill out my little how am I doing, and that's going to determine what course of treatment I need this visit. And then you're going to be able to tell Mike or any other technician that does this or that, here's the goal with this guy today. We need to take a look at this and that because he's going to have some surgery next week or whatever.
Sure. Yeah, I mean, people come in and at the time of their initial office evaluation, they present their symptoms to us. So, according to the symptoms that they're having, then that in many ways is going to direct how we evaluate them. And when Mike is doing an ultrasound, he's aware of the complaints that the patient has had, and will be aware of maybe looking at things a little more closely in this area or that area. But yeah, it all starts with the patient telling us what's going on. And then from the ultrasound, we're able to, anatomically know what's going on and then come up with a treatment plan for them.
Okay. The reason I ask is because I don't want my examination to go somewhere in a file. Okay. So I want to talk about what conversations that you all have based on a patient. Like, for instance, I asked the question when I was there with you, Mike. What's all that noise? I mean, when it goes, is that really what's going on in me? Or is that the machine letting us both know that there's this activity or that activity?
It's the machine's interpretation, it's the way it's interpretation of the motion of the blood, actually.
Okay.
So it's not the actual sound that we're hearing of the blood. It's just the machine letting us know that there's flow and also how fast it's moving.
I've noticed that when you tell people to bear down or to hold your breath or whatever, when you apply the pressure and then you release it, it's like squirting.
Yeah.
I think that's it. For a patient, I don't know what it was like before because the examinations I've had have all involved ultrasound. But I would imagine that before that, the doctor had to be pretty good, Doc. Because you didn't have that. So that's why it was what's more invasive, right?
Sure, yeah. Well, and more, the testing that we'd had for venous disease prior to ultrasound were kind of rudimentary kind of things that didn't give us anywhere near as much information as the ultrasound does. And they were more time-consuming and more bulky and that kind of thing. So more difficult to do. Now with respect to you were getting at, I think, where we store information and what is the information that we do want and where does it go? There's really three places. like Mike was saying, when he's doing an ultrasound, he is, taking still images or little video clips of the veins that he's looking at, and that's stored in the machine, or we can put it on a disc, so that we keep for a long time, indefinitely. Yeah. Now, secondly, we also have an electronic medical record that we input data from that ultrasound, and actually the electronic medical record that we have is kind of neat because you put in the numbers and the positions and all that sort of stuff, and it actually comes up with a nice little drawing.
Yeah, I've seen that's fascinating.
Yeah. So that's kind of cool. But then in addition to that, and probably the most practical thing that we have is after Mike does an ultrasound, he actually draws out what he has seen on a templated kind of stick figure that we use, and puts all the numbers and all the relevant information, so that so that when we do go into the procedure with a patient, we've got one thing that we can look at, and that's going to give us all the information that we need while we're doing that procedure.
Okay, so here's where I come in. I've just had my ultrasound. Now pretend that I've left the room. I'm not sure how often that you guys get to verbally communicate with each other about every patient, but typically, what would be the conversation when the doc says, "Okay, Mike, check this guy Mike out. We think he's got a clot down there. He's got this over here," and you do your thing, and then what happens to that information?
Well, I mean, the doctor or one of the providers will talk to me and tell me what the complaints are, what they think may be going on. Like, hey, keep a special eye out for a blood clot maybe in this area. Yeah. So I'll go in there kind of with a little background, and I'll talk with the patient a little bit too, and kind of get my own idea about what's going on with the patient. And, and I'll just check extra hard in the certain areas that I'm concerned about or that the doctor's concerned about. And yeah. The reason I ask that is because I know that when you discuss a treatment plan with the patient, after they've had that, no matter who discusses that, whether a nurse or whatever, that all of this information travels with that person to whatever outcome you're expecting.
Yeah, we don't have a personal conversation about each and every ultrasound that's done
pretty hard.
In the office, because 80% of the time it's relatively straightforward. We have again, when we're seeing the patient after the ultrasound, and at that point when we start to do procedures, we've got the written ultrasound report. We've got the diagram that Mike has done. So again, usually it's fairly straightforward. Now, are there some times when we do have to have a conversation? Oh yeah. Absolutely.
Well, there are degrees of illness, right, and severity. And I mean, when somebody comes in and they're a train wreck, pull all stops, everybody jump in.
Yeah, or like yourself. I mean, we see a good number of people who have had treatment before they come to us, or we treated them several years ago. So it's a little higher level of evaluation at that point, because we're trying to define what the status of the procedures that had been done before, but also find out what might be new going on with that patient when they come back in.
Yeah, I think it's kind of fascinating, because I feel confident, and Mike, this is where your ability comes in, so that no matter who picks it up, they're going to be able to say, okay, this is what ultrasound says.
Right.
And
yeah.
they're not going to. In other words, you're the doc in the procedure. You're the one that does the test, and the doc needs your info to make his decision on a treatment plan.
Yeah. So as the vascular technologist, I map out everything, and I try to be as detailed as I can on the worksheets, the reports that I write. I like to be able to write, reports and show my findings in a way that is very clear. So if a doctor's going into the procedure and I'm not in the exact same room, he can look at my worksheet there and kind of know exactly what's going on. And I'll put all relevant information onto the report. Sometimes the paper is just filled from the top to bottom with all kinds of information.
Yeah, like mine. This guy's in trouble, doc. Fix him up.
Yeah, sometimes there's just a lot of information to put down.
We had a lot of discussion about your mind.
Yeah. But here's the thing that I think is really critical, and that is, and it's not necessarily a comfort level, but it is a confidence level. That you have confidence in your technician to the point where you're making some very serious treatment plans or decisions based on what he has determined is going on in there that you couldn't see from outside.
Sure, absolutely. I think maybe what we should get comments from Mike on are what in the course of the ultrasound, what is he looking for that really is the information that we need? Venous insufficiency has to do with the fact that some veins in our legs are failing. Yeah. And typically that's from valve failure, one-way valves that are supposed to be keeping the blood moving in the right direction, which is up. And those valves fail, and the blood starts to actually move downward. Now, you were talking about the sounds in the machine, the swishing and all that sort of stuff. Yeah. But maybe Mike can kind of describe what it is that he's really looking for. And what does he have to do to make that happen? Just to give people an idea about what they're going to go through if they come in and they have an ultrasound.
Yeah, and I'm just supposing sometimes, Mike, because I've been doing this show, and by the way, we are rapidly approaching our first anniversary of this show, and they say, how can you talk about veins for an hour a week every week? And it's pretty incredibly simple to do because there's so much in it. But it must be that is, what must you get fired up on? And are there times, in addition to what Doc was saying, where you actually find something that nobody knew was there, and you, just because of your technique and your ability, you can say, okay, I think we better talk about this too, because look what I found over here.
Oh, absolutely, yeah. That happens all the time.
Yeah.
You go in and you can kind of see if somebody has varicose veins or swelling or skin discoloration, but you can't really look underneath the skin unless you're doing an ultrasound, and there's all kinds of different things that you can find in the venous system. So when I go into an ultrasound, I'm checking the deep venous system and I'm checking the superficial venous system. So I check the valves in the deep system, make sure that there's not any deep reflux, and document it if there is, see how bad it is. A lot of times there'll be deep reflux at certain levels of the deep veins where it can be corrected with treatment of the superficial veins. So I'm looking to see if that might be possible if they do have deep reflux. Then, as I'm checking the superficial system, there's a lot of different variations of the veins. So first, I'm checking the most common veins that are there, the great saphenous vein, the small saphenous vein. But then I'm also checking for any other sort of variations. I'm looking for anterior accessory saphenous veins, posterior accessory saphenous veins.
There's a lot of stuff going on there.
There's a lot of, there's a whole lot of different variations. And then there's variations of the variations. And, you're looking for perforating veins. That's another big thing, is finding veins that communicate with the deep and the superficial system and checking to see if those valves in those veins are working well. A lot of times you can find, tons of perforators in a calf, and they may be causing the symptoms just as much as say the great saphenous vein is.
Are there some times when a patient will say to you, "Hey, Mike, how bad is this, man? I mean, what's the scoop here? What can you tell me?"
Well, usually I leave that sort of information to the docs, but I'll let them know if that I think that we can help them, and I also let them know what I think they can do to help themselves. Compression stockings, leg elevation, things like that, especially with people who have deep venous insufficiency. It's I definitely like to recommend compression stockings for that.
Doc, when we say that, and I think you've answered this question for me before, but I think a lot of people are going to want to know, do you use the same procedures, or does Mike's work also involve the arteries? Because, obviously we know about the veins, and I know what the answer is already, but what sort of difference would there be in doing an ultrasound on an artery instead of a vein? Because you'd have to know the difference between them. I'd just say, hey, this guy's legs look great to me, but I have no clue that there's arteries and there's veins.
Yeah. Well, and we do evaluation of arterial problems in our office also, even though it's not our main concern. But we do arterial studies. Mike does arterial studies all the time. That sometimes people come in with a set of symptoms, and we're not sure.
whether it's
is
the
it
veins
due
or the
to
arteries.
veins or is it due to arteries?
That's great. I mean, it's great to hear that.
And so most of the time you can tell just by listening to the patient and looking at the legs, but sometimes you're not sure. Sometimes, as we talked about recently, you could have both. Both arterial and venous. So it's important for us to be able to do arterial studies too. Now, the things that we're looking for in the arterial system are completely different. The problem with veins is that valves fail and blood starts to go in the wrong direction. The problem with arteries has to do with plaquing. Blockages in the arteries.
Right.
And so the thing that we're looking for there on the ultrasound is completely different. Maybe you'd like to comment on that.
What's it like? I mean, I got this big old leg here, and we're going to look at my veins and my arteries. How in the heck do you tell the difference between them? That's the magic.
There's a lot of differences between the two. First of all, I mean
the direction is one, right?
The direction is one. Yeah, the arteries
I got that one right, Doc. Yeah.
The arteries have a thicker wall layer. It has an extra layer of muscle tissue that the veins don't have. So you can collapse veins with the ultrasound probe if you push down, but you cannot really collapse arteries too easily. Also, another real good way to tell is just by knowing the anatomy, and then also knowing that your heart is pumping the oxygenated blood through the arteries, whereas the veins, your heart's not really moving that flow along. That's all mainly respiration and calf movement. They call your calf the venous heart, actually.
Pump.
So if you sample the arteries with the ultrasound Doppler, you'll see like a nice rhythmic flow, like you would, like if you feel your pulse on your wrist. That's kind of how we see the arterial flow moving about. Whereas with the veins, it's more of like a slow, wavy kind of flow. And it varies depending on your respiration and movement.
And by the way, gang, you need to go to veinclinicsofhawaii.com and see some pretty dramatic pictures that will show you. And also it'll kind of walk you through some of these other things. And don't forget, a lot of our previous shows are archived, and this one will be too, one of these days when we get that up, Doc. But I think I have such a confidence level, not just in my work, but in your procedure. And I think that maybe that's why I think people that are out there listening, once again, explaining that in that leg of yours, there's a whole lot of stuff going on. So one would think that if you're an ultrasound operator, if you're a good one, your little probe will tell you what you're looking at all the time.
Yeah. It's the anatomy is complicated. Now the arteries, the arterial system is a fair bit more constant, from one person to the next than veins. Veins can, as Mike was touching on before, there's a whole bunch of different, variations on a theme. Arteries, not so much. So, we have an expectation for the arterial anatomy going into it. But all of that can be sorted out with the ultrasound. With respect to arterial flow problems, and again, it has to do with plaquing. But the main way that we
excuse me, Doc, isn't plaquing where the inside of your artery gets choked up with this plaque,
right?
And so it can't move the same volume of blood that it used to.
Exactly. And that it gets to a point once that blockage gets to a certain percentage. Then patients are going to start to have symptoms from it, whether it's leg or coronary arteries or whatever. But so the way that we look at that, when we're diagnosing venous problems, we're looking for that reversal of flow. Like you said, blood's going in the wrong direction, and we can actually see that, and that's part of the sloshing process that we hear, and we can visualize those areas where the valves are actually failing and the blood's settling downward. In the arteries, since there's more of a continuous flow because of the it's pulsatile, but it's a continuously pulsatile flow. We can see those areas of blockage in the artery not only by looking at it with the ultrasound, just getting an image, but we also use flow patterns, and that's another. There's a variety of different ways.
I'm anxious to find out a little bit about that. I think everybody would be.
Yeah, there's a variety of different things that we look at, and again, maybe Mike can touch on this. What are the things that we look at when we're diagnosing arterial blockage? One of them is the picture. One of them is flow patterns, and something that we call velocity, and how it relates to a blockage in an artery.
Yeah, Mike, there's another question, obviously, and we've spent a lot of time on the program talking about how an equal opportunity disease this is between men and women. However, pregnant women are a little bit different than men no matter what. What's the difference having to do, and can you tell on a patient, let's say, that had vascular treatments and then gets pregnant, is it more difficult to do ultrasound? Is it hard because of what's going on, or is it just different?
I wouldn't say that it's more difficult to do a venous exam on a pregnant patient or a person who has been pregnant. Pregnancy does make the venous insufficiency problem a little bit worse in a lot of patients, but it doesn't make it any more difficult than just a normal venous patient who has venous insufficiency.
Yeah, so that's good, Doc, that, you can still get a pretty good reading. There's one more thing before we go in and do what else you were talking about, is I'm very curious because I know that symptomatically I might feel something's throbbing or burning, and somebody else might feel it's hot or cold. And I would imagine that sometimes people are, giving you symptoms, when they're lying. They say, that hurts, or that's throbbing, or my legs feel heavy. Doesn't that sometimes help? Passing along more information. Here's a symptom that we hadn't discussed that the patient just volunteered.
Oh, yeah. I mean, I definitely speak to the patients, and I try to get an idea about what type of symptoms they have, and it definitely helps me kind of determine what may be going on, and it just kind of supports my findings that I find with the ultrasound exam.
Yeah, and Doc, and that must mean that there is it still fascinates me, whoever came up with the whole concept of doing this with ultrasound anyway, but it also just dawned on me, there's a lot of stuff in there, and I think you mentioned one time before, I asked if the lymph system was something that you did ultrasound on. In other words, there's a lot of things going on.
Yeah,
and there's some bones too.
Sure. Yeah, muscles, tendons,
all that stuff.
And unfortunately, the lymphatic system is very much goes hand in hand, especially with the venous system. And we've talked about lymphedema before, and the abnormalities within that lymphatic system. Unfortunately, we don't. Other than being able to visualize lymph nodes, which we can, we can't really see flow problems within the lymphatic system with the ultrasound, and primarily just because those lymphatic channels are so tiny throughout most of the extremity.
Yeah, that was a question that I had, and Mike, I'm sure that this comes up when people say, well, look, if something's really small, how do you see it? And if something's really big, how do you see it? So obviously, time, expertise, and knowing anatomy is so that you immediately know when you hit me with that probe what you're looking at.
Yeah, I mean, most of the time when I'm looking at the ultrasound, I know what I'm looking at because I've come across it probably more than a dozen times before, no matter how strange it may be. Yeah. But I mean, you run into the same thing over and over again, and you get used to what you're seeing. Do
you sometimes recoil at how bad off somebody is? I mean, not with being a specific patient, but Doc, I know that sometimes you see somebody that's literally limps into your office and they're in big trouble. And I'm guessing that a lot of times when you look at a person like that, it must be hard to think, how does this person even get around?
Oh, yeah. Sometimes I'm watching them walk to my room and I'm like, oh, boy, this one's going to be tough. I can just tell.
Yeah. I'm sure I used to be like that. They used to call me a tough stick trying to even do a blood test on me. Yeah. Because I do know that one of the things that we talk about, and that must mean extra work for you, the ultrasound technician, when somebody is obese or when somebody is, experiencing a lot of pain.
Yeah, it's not just obesity. I mean, sometimes super thin patients can be just as difficult. It just really it just depends. I mean, the superficial venous system can be really, really complex, and there can be a whole lot of things going on. And it's just and you want to document every little piece that you see, and you want to connect it all together, and also be able to explain it and understand exactly what's going on.
So that must be, in some respects, Doc. And if you go to veinclinicsofhawaii.com, you can see this stuff and schedule an appointment and get looked at. It seems to me that almost everybody owes themselves, at least at some point in time, what's going on in all of this stuff that's in my leg, because my leg's throbbing and I want to know why.
Yeah. Well, if they have symptoms, definitely. Yeah. Absolutely. Yeah. And, people tend to ignore symptoms until they're just intolerable. Yeah. Number one. Number two, a lot of the symptoms that people have referable to venous insufficiency, they don't know it's due to their veins.
Yeah, that's the next point that I want to cover.
That's one of the challenges that we have all the time, is just being able to, educate people. And by and large, when people come in, no matter what their complaints are, whether it's spider veins and that's associated with venous insufficiency, or bad problems with swelling and discoloration, etc. Very often they're surprised to find out that we are talking about veins in their legs. So with respect to the difficulty of any one study over another, there's a number of different things that can interfere with our ability to visualize the things we want to see. One of them is depth. You talked about that before. But the ultrasound works by emitting sound waves into the tissue that we're trying to look at, and those sound waves bounce off of the structures that we're looking at and comes back to the machine.
Up to give you a reading.
And that's what gives us our picture. But there's a lot of things, like, for instance, swelling. Just a simple excess fluid in the leg, that can get in the way of our ability to have those sound waves move in the way that we need them to show us the structures that we're looking at.
Yeah, and that's why, Mike, and that happens with me, because one of the things that I've had is chronic edema based on kind of really having a jammed up system for so long, although I deal with it. But there are some times when my legs are much more swollen than others, and I was wondering if that does cause a problem to the technician trying to get a good look inside that swollen leg.
Yeah, sometimes the technologist does have an issue when there's a lot of edema. I mean, the edema can get in the way. It can make things a little bit more fuzzy than we'd like them. Usually we can still get the information we need. I mean, there's other skin conditions, too, that make it just as difficult. Sometimes there's a lot of just random calcifications inside of the soft tissues, and sometimes the thickening of the skin makes it very difficult to see inside. So it's not just edema, but the condition of the skin and the soft tissue can affect the image quality.
Sometimes we actually have to initiate some treatment. Now, it's not the invasive kind of stuff that we do, but sometimes we have to initiate treatment for a number of weeks or even months to try to relieve that extremity of the swelling or the changes in the skin, et cetera, before we can get what we would consider a reliable ultrasound.
But I must tell you that I'm pretty aware now of it, to make sure I get my compression and my stockings, my elevation. But I'm around a lot, and especially here in Hawaii, and we've discussed this before. You see a lot more here because, we're wearing shorts and stuff. And then sometimes people get past the point of no return. They say, I don't care what it looks like. I'm wearing my shorts. I see some people, Mike, and it must be, does it sometimes amaze you as a technician how much these people are going through just to get to your office?
And it really amazes me that these people sometimes walk around for years and years with this issue, and it bothers them, it hurts them, but they don't really know that there's treatment options available. And that's a problem in the medical field that I've noticed, is that venous insufficiency is overlooked sometimes.
It may be, and I think one of the things that you've talked on, Doc, before, and some of our patients that we've had in previous shows, a lot of that is because, like you say, this one particular disease comes on very, very slowly. And so the symptoms, you may not even attach to it.
Sure.
You might just think, hey, when you talked the last couple of shows about restless leg syndrome, and I would guess, Mike, when you are doing an ultrasound, some like that's one of the things the patient will share with you, that, hey, is that pain that I'm doing at night, or that restless leg syndrome, is that because of my veins?
Oh, absolutely. Yeah, absolutely. And I'll ask them questions, and sometimes I'll ask them, do you have restless leg syndrome? And they say, well, yeah, but is that related to my veins? And they're shocked to hear that yeah, it is. Definitely, it can be.
Well, I remember the old song, knee bone connected to the neck bone and all that stuff.
Yeah.
I mean, it appears to me that almost a lot of people, Doc, maybe they're in denial. They don't realize how bad off they are, or maybe even how bad the quality of life that they have are, because their system's not working right.
Yeah, and they've grown used to it. But yeah, I think that venous symptoms and venous disease in general in this country has been ignored tremendously for many, many years. Now, part of it is because of the fact that some of the symptoms that we deal with, the patient can't connect with vein problems. Some of it is, back 30 years ago, when all we had was surgical vein stripping and very invasive kind of procedures, there was a much higher threshold before people would even want to be treated. I mean, they had to really feel bad before they went for vein stripping. So I think it was ignored that way. And again, not everybody, and we try to educate not only the general population, but the physicians that we deal with, and to make sure that everybody knows the extent of symptoms and et cetera that come along with venous insufficiency, and it can be treated very easily these days.
Yeah, and the other side of it is, because it takes so long to collect, I think that everybody needs to find out, and this is just a plug for getting an exam, where you sit on the chart. I mean, everybody fits somewhere on the chart of venous disease. Maybe at the very bottom you don't have any. But I think, Mike, sometimes, and some people are to this other end of the chart where we're going to talk about in a bit, these where we have ulcers, and that's like really bad stuff. But you said something earlier that I think needs to follow through, and that is a lot of times, it's not a large percentage, I know, in vein clinics of Hawaii, but a lot of vascular stuff is spider veins and cosmetic stuff. Are there times that you discover during an ultrasound, if one is even done on some of those, very superficial things, that you can't see what's going on inside, but there are issues? The patient doesn't know, there's nothing bulging out or sticking out, but you might be the bearer of some not very good news every now and again with an ultrasound.
Well, yeah, definitely. I mean, some there's a huge spectrum with venous patients. Some patients have no visible signs whatsoever of venous insufficiency, but they'll have some of the symptoms like cramping or swelling or restless leg syndrome, and they won't connect it to venous insufficiency or to a vein problem because they don't have the classic varicose veins, so they won't really connect the dots there. And then on the other hand, you'll have patients with varicose veins who may not have any cramping or restless leg syndrome. They'll have, maybe they'll just have a little bit of swelling or edema in their legs, or maybe they'll have just a little bit of pain here and there. So there definitely is a spectrum. Sometimes you find patients with tiny little veins with lots of reflux, and usually the more symptomatic patients have larger veins.
Stick out, really.
But sometimes you find patients with tiny little veins that are only 2 millimeters in diameter, and there's like a few seconds of reflux, but they have all the symptoms. The pain, the swelling, the cramping. The restless leg syndrome, and so there's definitely a spectrum. There's not a clear cut mold for venous patients.
Okay, so here's a question, Doc. Generally speaking, if somebody comes up with what they think is a vascular issue, or somebody in the family says, "Oh man, well, I think we got it," so obviously they come in. You got I have to tell you that they want the names of your unborn children on this question and answer thing. But the more thorough it is, the better a picture you get.
Yeah.
And I know that this has been developed with malice aforethought, that there is a path that goes through. And if a patient is honest with those questions, you can really cut through a lot of the exploratory stuff, particularly when then you send the patient to Mike to get an ultrasound.
Yeah. The reason why we have that iPad questionnaire.
Yeah, but it's very convenient.
Yeah, well, I think it's good. A lot of people don't like to go through each and every question,
Right.
but yeah, it really does help us narrow down, what's going on with this patient. And in the long run, actually, it saves time because otherwise we'd be the ones, asking all
Of
those
course, yeah.
questions. But it helps. And, a complete history is important, not only as it pertains to their symptoms, when they arrive, but also their past medical history, what medications they're on, allergies, all of that. We've got to know about that because we're going to be potentially doing procedures, giving them medication. And, it's pertinent information.
One of the things that you talked about before was swelling. And I guess, Mike, you said that swelling, if you're really swollen, it's harder to get a good look, at what you're doing with the ultrasound. But obviously, some people are there because of the swelling. So you still got to be able to take enough of a look so that they can start getting some treatment, if not to do anything else, but reduce the swelling so you can do a better job. Is that a good question?
Yeah, I mean, a lot of times the patients will come in for swelling, and it might be a little bit difficult to see everything that I want to see. But usually, I can get the information that I need, and if the swelling is bad enough, we can do treatments before the ultrasound that kind of minimizes the swelling enough to where I can get the information that I do need.
Sometimes all we need to do is to put a compression wrap on somebody's leg and, encourage elevation and all that sort of stuff. And that makes a tremendous difference. I'm sure you've seen that in the past.
Absolutely. No, and even with me. So I'm thinking if you are wearing compression socks. And one thing I do know, that, before you get surgery, vascular surgery, that the insurance companies particularly want to know, well, what have we done so far? And one of them might be, do you elevate your legs? Do you wear compression stockings? In other words, they're not going to automatically give me a get out of jail card unless I'm participating. Right.
Yeah. We're mandated, and not only mandated, but the best medical practice is to treat people as conservatively as you can,
of course,
and see if that's going to be enough for them.
Sometimes it is, right?
Well, absolutely. I mean, I just saw a patient not very recently who was elderly, had a lot of medical problems. Had bad venous ulceration. However, we were able to get it healed with compression and then ultimately stockings and that sort of thing. We decided to not intervene on him just because of his age and multiple medical problems, and we'll be monitoring that, but presumably conservative therapy is going to work for him. But by and large, everybody needs to go through that conservative therapy period before we recommend invasive therapy.
Okay, now before we run out of time, I want to emphasize another thing. Go to veinclinicsofhawaii.com and see what we've been talking about a little more graphically. But I wanted to save the best for last because I do know, Mike, that sometimes a patient is treated for a dermatological situation where they think that they've got this rash on their leg that's a skin rash and it's indicative of something else. Is it possible to get a good ultrasound on somebody who has real bad skin issues or ulcers?
It is. It is. I mean, we like to minimize the amount of skin issues that the patient has before the ultrasound is done, but that's not always feasible. We're not always able to close or heal the ulcers before the ultrasound. So there are sterile techniques to do the ultrasound exam to where we can look inside and see everything we need to see, is even with an ulcer there. Skin issues, that might fuzz up the image a little bit, but generally we can get the information that we need, and then at least enough to treat the patient. And then if there's any other veins that we didn't see because the skin condition was so bad, then we'll have an easier time seeing that once the treatment has begun.
That's important, and I want to make sure before we're done that there's no way that you're not going to be able to get a look eventually.
Oh no, we'll always be able to get a good enough idea as to where to start helping the patient.
And Doc, we talked about that at the end of the venous issues. Outside of big clots are these ulcers that really need help. So it must be you need to find out what's happening around and beneath that ulcer to really have a good treatment plan.
Yeah. And in particular, concerning ulcers, Mike mentioned perforator veins before. Those are little short veins that connect the two venous systems, the deep and the superficial. And we often see reflux in a perforator in the area where an ulcer has developed or where an ulcer is not healing. And with respect to that, I mean, sometimes depending on how extensive the problems are with a patient, we don't do everything like right away. We do what we can, just kind of get to a little higher level of, the status quo. And then, maybe other things become evident, or maybe there were things that we weren't able to do initially and we need to, correct as we go along. So it's sometimes it's more than just a one-stage deal.
That means that we're going to have to get you to come back, Mike. Thanks so much for being with us today. Appreciate it. And we'll see you at the office because I'm going to be there myself.
Yeah, I'll see you then. It was a pleasure. Thanks for having me.
Thank you, my friend. And Doc will be back next time. In the meantime, if you want to know more, it's so simple. Go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.